fibrosis and bronchiectasis, cardiac dysfunction, and it's important nationally to consider TB in endemic areas, which I don't think we're in with the normal chest x-ray, but depending on where you are, what population you're thinking of, you should be thinking of TB. So again, what happens when the cough doesn't go away? When you've gone through this paradigm, diagnosing and treating, okay, what do you have? And basically, you're either going to have refractory chronic cough, those that you try to identify a source and treat it, but they're still coughing, or those that you have investigated for a source and don't have any identifiable source, and it's unexplained chronic cough. So something else has got to be going on. And this is an older slide, but it's really relevant for these observations. Most patients with GERD, rhinitis, asthma, don't cough, okay? So, this is a subpopulation of these diseases. This next line, I think, is the most dramatic, okay? What parameter and biomarker distinguish those with GERD, allergic rhinitis, asthma, from those who cough or don't cough? And the silence is always deafening. There isn't any. So it's not about that intrinsic disease that's defining who's coughing. There must be something else going on. Okay? And furthermore, it suggests that the GERD, the rhinitis, the asthma, the non-asthmatic eosinophilic bronchitis is triggering something else. And it is. And that is a dysregulated cough reflex. And the term that you're going to be seeing out there in the literature is cough hypersensitivity. You're going to be seeing RCC, UCC, and cough hypersensitivity in the literature because that's the expected nomenclature. And while at first you would think this is a diagnosis of exclusion, it is not. Because there are clinical characteristics I will show you that you can go back into your office and ask these patients. And they will say, aha, I think I'm dealing with this new recognizable disease, cough hypersensitivity. Okay, now, to understand this, we need to understand what the cough reflex is all about. There's two cough reflexes. Actually, there's only one true cough reflex, and that's that primitive mechanico-sensory true cough reflex. These are the things that when you, after lunch, at lunch today, when you're talking vigorously and you suck down a piece of chicken inadvertently and you immediately cough it out and saves your life so someone doesn't have to do a Heimlich, that is the true cough reflex. These are receptors in the larynx, trachea, and carina. It occurs in the conscious but unconscious state, and we'll see that clinically because we see this other cough reflex goes away during sleep. And mechanically, it works on the very quick vagal alpha-delta myelinative pathways that go to the midstem and go back very quickly. There's no thought, there's no suppression. It's very hard to suppress this, okay? Now, what we're talking about when we talk about dysregulated cough reflex is the chemosensory cough. And the most important thing, which a pause, is that this is a sensory, triggered off by a sensory sensation. There's almost a universal urge to cough, and I personally use the term leads to a cough response. It's not accepted out there. We'll talk about the cough reflex. But this is not a reflex. You get a tickle, you recognize it, and this is the itch. This is the itch that you scratch, okay? We don't talk about, the itch reflex. We talk about your skin itches. You sit there and go, scratch it. And that's what we're talking about here. It's that tickle in the back of your throat. It's triggered off by irritants. It's triggered off by lung inflammation. And viral upper respiratory infections are probably our most potent trigger for this. And I'd like you to think about the cough with the common cold and COVID and the mechanism of that. And I suggest to you it's due to inflammation, but also it's neuropathic irritation. It's a neuropathic response. That cough occurs after the mucus. It can go on for days to weeks to months. And I suggest to you the mechanism is primarily neuropathic. These receptors are in the larynx, the bronchi, the upper airway, and I suggest the esophagus, even though a lot of people haven't looked there. It occurs in the conscious, but not when you're asleep or anesthetized.